My name is Dr. Jeff Davis, and I'm the owner and medical doctor here at Prairie Health and Wellness, and I practice with Jolene Zivniska, who's my nurse practitioner, and Kristen Marvin, who's my naturopathic doctor. We are a clinic that focuses on functional medicine, which means we try to get to the root cause of problems, and when we can, we use lifestyle and natural remedies to fix a lot of the problems that we see today. So tonight we're talking about testosterone deficiency in the male. Our last presentation was on libido problems in females, and it was very popular. We did not record that one for YouTube. This one will be recorded so that men can watch privately. All right, so testosterone deficiency. The definition of testosterone deficiency is an absolute or a relative insufficiency of testosterone or the metabolites in relation to the needs of the individual at that time of their life. And that's from Carruthers, The Diagnosis of Androgen Deficiency in the Aging Male. So this is a common problem that we see, and I think it's vastly underdiagnosed. We commonly associate it with older men, but I do have men in their 30s who have this problem. And so I wanted to kind of outline tonight why we have testosterone, what its function is in the body, how we produce it, and then how we safely replace it in men who have a low testosterone. So this slide here is the steroidogenic pathway. And I don't want to go into a lot of detail other than just to show that the very first building block of all of our steroid hormones is cholesterol. And I think it's interesting that we do see some men who have very, very low levels of cholesterol because they've had coronary artery disease or they've had a heart attack, and their cardiologist is trying to drive it as low as possible. The cardiologist always gets excited when it's in the teens. I get a little nervous when it's that low because I know that we're affecting this pathway here. So from cholesterol, we can push things through a couple different pathways. We can go creating the end product of our corticosteroids, which is aldosterone, corticosteroid, and cortisol. These are our stress hormones. Or we make our sex hormones. And the sex hormone, the dominant one for men, is testosterone, dihydrotestosterone. And then we make a little bit of estradiol and even less estrone, but those are important as well. So we're going to kind of dive into a little bit about how this process works and talk about where things can kind of fall off the rails. So again, I think this is an underdiagnosed problem. If you read the studies, the prevalence varies depending on what you call testosterone deficiency or how you define it. So again, an absolute or a relative deficiency in relation to the needs of the individual at that time in their life. So some say it's 10%. I think that's really an underestimate, and that's probably using the strictest absolute deficiency of testosterone. Most of the studies that are done with a total testosterone of less than 300, and there are men, I think, who are symptomatic in the 300 and 400 range. So it's probably missing a lot of those. So other studies have said 30 to 60% of men in their 70s are testosterone deficient. And I really like this third way of looking at it because it compares the men in the 50 to 70 year range with those in their 20s and 40s. And this probably doesn't come as a surprise, but at age 20 as men, that we are the best at creating testosterone. And you can probably look around most college campuses and figure out why that is, but and then we have a slow age-related decline after this. But in this definition, if we compare the 50 to 7-year-olds with the 20 to 40, 50% of men in that upper age group will have a testosterone that's below the lowest level of the men in the younger age group. So we do know that testosterone declines with age, and I hear a lot of men say, well, isn't that natural for testosterone? Because we see this in populations that testosterone goes down as we get older. And I think it's a real struggle to know what is a natural decline in hormones because none of us live in a natural environment. We're constantly being exposed to chemicals, we're exposed to stress, we have altered circadian rhythms because of artificial lighting. I mean, there's a lot of things that influence us that are not quote unquote natural. So I guess to really know whether that's a phenomenon of aging and is natural, we would probably have to go back to Adam in the Garden of Eden and say what were his testosterone levels as he got older. But we do see that this decline with age, and we'll talk a little bit more about that. So the effects of testosterone. What does testosterone do for us? I kind of talk, when I talk to my male patients who come in and they've been diagnosed with testosterone deficiency, I tell them that testosterone is the fuel that drives their engine. It's the diesel for a man. It's our vital hormone. It's what makes us who we are. So it's very important part of making protein. We think of men who have a lot of testosterone to have a lot of muscle mass. It also helps with muscle function, so it's going to help muscles recover faster from damage. Hypertrophy, muscle remodeling is controlled by testosterone. Bone formation for men is predominantly a testosterone issue. We do respond to estrogen as well, although we need very little estrogen for bone formation. It helps with tissue utilization of oxygen, and oxygen is really the last step of a cycle called the Krebs cycle that all of us in med school hated memorizing. Hope we never saw it again. And it's all about the oxygen is there to accept the final electron so that we can create energy. So again, if we have a normal level of testosterone, we should be able to utilize oxygen better. And it helps us control blood sugar. So this is something we see commonly in men who are diabetic. And now the Endocrine Society recommends that all diabetic men be screened for testosterone deficiency because of its control on blood sugar. So what are the effects of testosterone? I really love this picture because this little kid probably didn't have a lot of testosterone, but you can tell he's working on it. And I show this picture for a couple reasons. One, there was a study that actually showed that men who assumed a large dominant posture actually secreted more testosterone. And we know that testosterone helps a male achieve a position of dominance, and if a male is dominated, then their testosterone levels go down. So I think it's really interesting that we could all stand in front of the mirror like Superman and probably make our testosterone levels go up. We would tell our body that we're ready to occupy more space. So having men assume a more confident posture can probably help in that way. So this kid's really working on that. So it helps us maintain our immune function. It's important. As it goes down, we become more susceptible to lots of illnesses. It helps us with mental function. Men who have low testosterone will also often complain of mental fogginess, or they're just not as sharp at their job. They have difficulty with complex calculations. They get lost in routes in the city where they normally are able to find their way pretty easily. It improves our mood. Men with low testosterone can often be irritable, depressed. They don't feel good, and mood is one of the reasons. And I think a lot of them inappropriately get started on an antidepressant when really what they need is more testosterone. Sperm development, it's very important. This one's kind of a two-edged sword because men who have low testosterone don't make very good sperm, and if you try to replace their testosterone, they won't make sperm at all. So probably some of our toughest patients are the younger men who have an absolute testosterone deficiency and still haven't made it completely through their childbearing or child-producing years, I should say. And it helps us regulate cholesterol. So that high cholesterol patient sometimes is because of a lack of testosterone. And it kind of makes sense. If we were making it into testosterone, we'd be pulling that cholesterol out of the blood and making it into something more important. So how do we produce testosterone? Well, 95% of it comes from the testicle. That's the male equivalent of an ovary, and it's made in the Leydig cell. And about 5% of it comes from the adrenals. And the adrenal glands are these really tiny glands. They're very important, and they sit on top of the kidneys. Or kidney, another name for that is the renal, as it pertains to kidney. So adrenal is next to kidney. The stimulation signal comes from gonadotropin releasing hormone. So that's what GnRH comes, and that comes from the hypothalamus, which is up in the brain. And then from the hypothalamus, it goes to the pituitary, anterior pituitary gland. So this is a flow chart to kind of show how that works. So the releasing hormone says to the anterior pituitary, make more of these two gonadotropin releasing hormones, which are luteinizing hormone and follicle stimulating hormone. They then go act on the testicle. The testicle then makes testosterone, and then testosterone goes back and has a negative feedback on the gonadotropin releasing hormone and a little bit of negative feedback in the anterior pituitary gland. So this is kind of, a lot of systems in our body work this way. And if you go back and look at our thyroid talk, the thyroid stimulating hormone tells the thyroid to make more hormone, and then that comes back and the active hormone tells the anterior pituitary, we're good, stop secreting the stimulating hormone. So a lot of processes in our body use this negative feedback loop. So what are the signs of andropause or menopause, as I like to call it? And it's funny, I had a man in my office who was talking about his wife going through the change, and he called it menopause, and that's the first time I'd ever heard that called menopause. So signs of andropause, probably the most common one that men seek my help for is fatigue, and I would say about half of them come in because they're just tired. They don't have the energy they used to have. They don't feel like they can accomplish what they used to accomplish. And so they come in and they think it's their thyroid. They think they have anemia or something like that. And it really turns out that they're not making their androgens. Depression. I think all men who've been diagnosed with depression need to have a screen for their steroids, especially the male sex hormones, to know whether they're making enough of those. Irritability, we kind of talked about how it affects your mood. Anxiety can be another sign of andropause. Loss of memory is another big one. Loss of sex drive. So libido, or a male's sex drive, is lower when they have low testosterone. One of the later effects is that they lose erections. And this is I think this is difficult because I have a lot of guys who say, it can't be low testosterone because I can still get and maintain an erection. And I think this is really probably a later effect. And once you've been depleted for a very long time, you lose this ability. That does get men coming in the door pretty quickly. And usually it's for Viagra or something like that. But I always go and see whether we have problems with the hormones. Because if we can correct that, we correct a lot of different things. And then the risk of diabetes. With andropause, your risk of diabetes goes much higher. There's a decreased intensity of orgasm. There's weight gain. Loss of fitness, so inability again to do the things you used to do, a decrease in job performance, bone loss, because again our testosterone helps us build stronger bones. We get an increased cholesterol when the testosterone goes down, and we have an increase of risk of heart disease. Now this last one I kind of want to make a special point because there was a study that was done by the VA, and that study hinted that testosterone replacement was causing heart disease in men. And the study has been critiqued by multiple authors and multiple investigators around the country and has been pretty much debunked. The study was done poorly. It wasn't measuring the right endpoints. But it did, I think it helped us because we really went back and as investigators and researchers, we really investigated this to look at the literature and say, do we see this correlation? And really when you review the literature, you see just the opposite. That the risk of heart disease is much, much higher in men who have low testosterone. But I do think it's important when you replace testosterone to do it carefully. There's some pitfalls that we'll kind of talk about with replacement. So causes of low testosterone can be divided into primary and secondary. Primary just means that the problem is in the testicle. And so an undescended testicle doesn't happen very often, but every once in a while we'll find a teenager who's not developing as quickly as his peers, and we find that he has a testicle that hasn't fully dropped. The testicles are really sensitive to heat, and so if they are getting too much body heat, then they don't function as well. Infections like mumps and Epstein-Barr. Epstein-Barr is the monovirus, very common infection. In fact, we see a lot of mono in our clinic, reactivated mono especially. Hemochromatosis is iron excess that can also affect a lot of different organs and their ability to produce end products. Obviously mechanical injury, crushing, being kicked by a horse or a bull can cause permanent damage and scarring to the testicle. Cancer treatments. A lot of the chemotherapy that we use in cancer can decrease the ability of the testicle to produce testosterone. Alcohol also decreases that. Our diet, if it's a poor diet, rich in refined carbohydrates, that can decrease our ability. And then varicocele. This again kind of pairs with the undescended testicle. Really, there's just too much heat because of the veins that are, it's a mass of veins that are surrounding the testicle, and that increased blood flow can decrease testosterone as well. So secondary causes are things that are outside the testicle. Obesity is probably the biggest one, and Aging. Again, aging is an all-inclusive term, and I think it doesn't do a very good job of explaining what's happening because so many things happen in the aging process. And I think the decline in testosterone probably accelerates some of the aging that we see. And drugs. This one's very important. So opiates, and I would say American usage of prescription opiates has expanded vastly. In fact, the FDA is kind of worried about this. It's now the most commonly abused drug of all the drugs of abuse is drugs that people are getting from physicians. And so that's a risk factor for decreasing testosterone. HMG-CoA reductase, probably the second or third most commonly prescribed drug. So these are our statins, simvastatin, Lipitor, Zocor. All of those can also decrease the production of testosterone and the conversion into the active form. And then the cannabinoids. I put opiates in there twice. They're that important. So cannabinoids is in Kansas we can't legally use this, but in Colorado I imagine that there's some testosterone that's going down from the recreational use of cannabinoids. And then stress and illness can cause this. We see men after surgery or having a stressful event or having an acute illness, their testosterone levels can drop temporarily. So what is the lab work that we do? In our clinic, we check quite a few things, but the first thing we check is a CBC, and that's a complete blood count. And the reason we check that is we need a baseline because, again, it's going to identify those with potentially having hemochromatosis if the hematocrit's very high. But more importantly, if we start testosterone replacement, we want a good baseline on this one so that we can follow the changes in hematocrit. We check a testosterone free and total. And that's important. I think a lot of men they might have a normal free testosterone when you check in the morning, and that's important to check it in the morning. But their total testosterone is very low. And I kind of liken it to, we have an old windmill on our property, and there's a 50-foot hand-dug well attached to this. And when you first turn on the windmill, and the windmill starts spinning, the pump starts going up and down, water flows great. I mean, it's coming out, just gushing out. About 30 minutes later, nothing. So I look at total testosterone as being the water that's in the well. You can't use it. You can't do anything with it. You have to get it out of the well, through the pipe, and out to the garden or the pond or whatever you're trying to fill. And the free testosterone is what's coming out of the hose. And so just saying that you have enough free testosterone at that one point when you checked in the morning, you might find that well goes dry very quickly, and that the rest of the day they're bottom of the tank because they've emptied as much free testosterone as they can have. So it's important to check both of those. Dihydrotestosterone, there can be problems when this is much too high or if it's too low. This is a very powerful form of testosterone, although we secrete very, very little of it. This one is a factor in male pattern baldness. So we don't want it to go too high in men who are getting replacement. And then sex hormone binding globulin is one that I think is often overlooked. This is a protein that's created mostly in the liver, and it actually allows us to carry the dihydrotestosterone and estrogen as well, and the testosterone around to the different tissue, and allows us to unload it. And there can be problems when it's too low, and there are also problems when it's too high. So we check this at baseline. A lot of the products that you see on the internet that say they'll boost your testosterone, really they're herbals that are focused on dropping the sex hormone binding globulin. And so they will work in some men if they have an excessively high sex hormone binding globulin. I don't see that problem very often, which is why they probably don't work very often. But in a special subset of men, I think that some of the herbals like tribulus, which is horny goatweed. I wish all drugs were named like that you could just, the name tells you this is what this is for. Some of the other herbs can help lower sex hormone binding globulin as well. So sex hormone binding globulin we kind of talked about. I think what's interesting about this particular molecule is that as we have a decline in our free and total testosterone with age, this binding globulin actually goes up with age. And so you get this paradox of your free testosterone and total testosterone going down. And remember, sex hormone binding globulin is there to bind it and take it around to the tissue. But as it increases, more and more gets bound in the bound form, and it can't actually be delivered to where it needs to go. So the relative deficiency is much higher in these men in their 70s because their sex hormone binding globulin is so high. So how do we fix this problem? Well, replacement. So replacement has been studied back since the 70s, and we have many randomized controlled trials and uncontrolled trials that really show that it provides even a significant benefit for older men. And this was the latest study that came out in the New England Journal of Medicine, was specifically asking, is testosterone replacement in older men going to be something that improves their quality of life? And there was a significant improvement in quality of life in even the oldest men receiving replacement. So therefore, there's no age which we would say testosterone replacement shouldn't be considered. If a man is healthy and if the risk factors are there where he needs replacement, I think it's a benefit to give it to him. So let's talk about the risks and the benefits. So again, prostate cancer, I don't feel is a risk. Testosterone won't cause a prostate cancer, but it can grow faster with that, so check a PSA annually. I have had one male who did have a prostate cancer, and we took him off his testosterone, although his urologist said probably no reason to even take him off the testosterone because his dihydrotestosterone was in the normal level. He felt uncomfortable with that and wanted to go off of it. Replacement can cause our hematocrit to rise, and this is really the thickness of the blood. And probably the reason that most athletes are using testosterone is when you increase hematocrit, which is what blood doping does as well, you increase the ability to carry more oxygen to your muscles, and so therefore you can utilize muscles more. And so Lance Armstrong, this is what he was doing primarily. Testosterone can aromatize into estrogen, so it's important for us to check that. Men don't look good with breasts, so we don't want to see the estrogen go too high. We do need a little bit of estrogen. Every once in a while I'll check it in men who are on specific medications to block this aromatase, and it's gone too low. And so it has to be constantly adjusted and monitored because we do need a little bit of estrogen to build bone. And then again, replacement can lead to hair loss or male pattern baldness. And this probably has more to do with producing too much dihydrotestosterone. And there are medications that can block that production as well. And then it can worsen an untreated severe sleep apnea. Now, the reason I put an asterisk on this point is that it's an interesting phenomenon. Men who have low testosterone are at risk for sleep apnea, and men that first start on testosterone have been shown to have a worsening of that sleep apnea. So if men snore, if they have a lot of fatigue, headaches when they wake up in the morning, they fall asleep easily in the car, I screen them with doing a sleep study, and we make sure that we treat the sleep apnea while we're putting them on testosterone replacement. So what are the different forms that we can replace testosterone with? There's probably almost every form you can imagine has been studied or being currently used. Transdermal is probably the most popular commercial form of testosterone replacement, and these are your androgels, Axiron, Testoderm. There's a testosterone patch that's also used. And so these transdermal creams or gels have to be applied daily, sometimes twice a day. There's a new nasal testosterone, so you can actually squirt the testosterone gel on each side of the nose, and you pinch your nose and it spreads out. So any tissue that has a good blood supply can soak up this testosterone. We know the skin is an amazing delivery device for different transdermal therapies. The problem I have with transdermal, you have to be very careful to select the right patient for it. If a patient is, let's say, has young kids, and my wife and I, oftentimes we wake up in the morning and we've got our 6-year-old in bed with us, and if that person is snuggling with their dad and the dad has put on testosterone gel before he's gone to bed, that will transfer to the child. And there have been a lot of studies that have shown that that is a significant risk. And then, of course, if you're spooning with your wife and you've put this testosterone gel all over your chest, and your wife develops a beard, she will be upset. So this is not probably my favorite way of replacing it. I think the underarm Axiron probably gets a little bit around that risk because, again, it limits it to the underarm area. That form of replacement, though, can be very irritating. It has a high alcohol content. It's really runny, oftentimes drips down the side of the upper torso. So transdermal, even though it's the most popular, it's not my favorite. The intranasal one's $600 a month if your insurance doesn't cover it. The transdermals, androgel, the last time I looked, it was over $400 a month if your insurance doesn't cover it. And we're seeing a lot of pushback from insurance companies on covering these gels, especially for our older patients. So injectable. The way injectable it was FDA approved was once a month. Testosterone cypionate's one of the more common ones. There's also propionate and anthenate, but cypionate's by far the most common one that we use. It's in a sesame seed or a soybean oil, and it's injected into the muscle. Normally, I've seen people come to me, they've tried testosterone injections, they say that it doesn't work, they don't like it, and you ask them how they were taking it, and they were injecting it once a month. And so what happens is you'd have to give a very large dose, and so they get this super physiologic dose starting out, and then the rest of the month they're just on this continual decline. And so it's a little bit of a roller coaster when it comes to replacement. So some practitioners have gone to giving it every 2 weeks, and you get a little less peak, but you still get that fall. And so if you grafted out and did testosterone every day, you'd probably see that about half the month these guys are really in the lower range, and probably a quarter of the month they're above the normal range. So the way we do it in our clinic is we dose it in very small amounts and we give it twice a week. So now we're getting a nice pulsatile, probably more physiologic release of testosterone. You're able to use a smaller needle. You can give it more comfortably. We train our patients in our clinic to give testosterone to themselves. And I'd say probably the most popular form of replacement for us from a cost standpoint is the injectable. A bottle of testosterone, if you're paying cash at CVS pharmacy, last I checked was around $65 to $67. And that lasts about 3 months. So $20 a month or $400 to $600 a month. And I tell people, doesn't matter what form they choose. I'm comfortable using all of them. It really just comes down to preference. And of course, transdermals, if they have kids that are young and going to be climbing in bed with them, I recommend them not to use that. Buccal testosterone is a really interesting way of replacing it. This is made into a troche. And the nice thing about this form of replacement is we can put other things in the troche. So if we wanted to add some pregnenolone or we wanted to add some DHEA, we could do that. If we wanted more testosterone in the morning and you wanted to use less in the evening, we could adjust it that way. And it's just a wax square tablet that dissolves between the cheek and gum, goes right into the bloodstream and bypasses the liver. So all of these methods are trying to bypass the liver. And the reason is if you take a testosterone pill, and there's one that's approved, but no one uses it because of the liver toxicity that it causes. If you take a pill by mouth and it's absorbed in the small bowel, it goes through the portal vein, which then goes to the liver. It gets conjugated and glucuronidated, and all these things happen in the liver. And you have to give very high amounts of testosterone to be able to get a little bit of testosterone out of the backside of the liver. So most forms of replacement are trying to bypass what we call first pass hepatic metabolization. So transdermal, injectable, buccal, all bypass the liver. Now I'll talk about an interesting form here in a second that is oral and also bypasses the liver. So pellets, I have been really surprised. A lot of men really like pellet therapy. And the benefit with pellets is that they're placed underneath the skin. They last for about 3 to 4 months, and they give a very constant release of testosterone. These are FDA approved through a company called Testopel. We also have a compounding pharmacy that makes pellets for us in different doses. The cost on it averages about $100 a month. The benefit, again, for men who may travel a lot or just can't handle giving themselves injections, don't like doing troches twice a day, or don't want to have the risk of the transdermal, the pellets are really nice. The side effect of the pellets, really the only risk is that you might have an infection, and that's really goes with anything we put under the skin, and you could eject a pellet. This pellet ejection has happened to me probably 3 or 4 times over the last 6 years, and people will say they feel like a little pimple, pop it, and a little pellet pops out. I use a trocar that's about this long and put the pellets right above the belt line in the love handle, and so it amazes me that the pellets can migrate that distance, but they sometimes do. The other downside to using pellets is as I'm putting them in the love handle, one thing I've noticed, the longer men are on testosterone therapy, the smaller their love handles get. And so it gets increasingly difficult to put the pellet right in the fat layer. I use a technique called tumescent anesthesia where we use a weak solution of lidocaine and bicarb, And for the most part, men don't feel the pellets going in at all. And I think some of you guys have watched me put those in. And it's pretty amazing that you can put that trocar in and lay those pellets out, and most men don't feel it at all. So it's a very comfortable way. It takes me about 5 minutes to do here in the office. And again, it's very convenient from the standpoint of we put the pellets in and they just have to forget about it for the next 3 months. And then oral. So this one, the reason I wrote experimental on it is that we have an FDA trial that's starting, I believe, next week. And this is on a testosterone undecanate, which is an older form of testosterone that usually we give injected. The company that makes this testosterone, they've been working on it for 13 years, and they've paired the undecanate molecule with an ester, which makes our body believe that it's a fat. And so as you're ingesting the testosterone undecanate ester, and if you ingest a high-fat meal, it goes through a different transport system. So normally we ingest a meal, things go through the portal vein and into the liver. There's a chylomicron transport, though, that's taken up through the brush border, and it gets dumped into the lymphatic system. And then from the lymphatics, it goes up into the thoracic duct and then into the heart and then out to the rest of the body. So again, it gets to skip the liver, and this testosterone is cleaved by just esterases that are present in our blood. So it's an exciting study, and we're looking forward to doing it, because I think almost all my men that I start on replacement, I go over the various options, they all look at me and go, "Can I just take a pill?" And so the answer is no, unless this one gets FDA approved. They've gone through 3 trials so far, and all of them have been effective and safe. This 3rd trial is going to be looking specifically at 24-hour blood pressures, and also we have to get more detailed information on the meals that they're eating with this particular testosterone replacement, make sure that the fat content is something that people can handle with a normal meal, which in our clinic, we love high-fat, low-carb meals, so it would work really well with our patients. So I want to touch just a little bit on the coronary artery disease question, because I think that's the one I get the most. Even other physician friends of mine will say, I really know my guys need it, but I'm just worried about the testosterone causing heart attacks. So I'm going to just go through a few of these studies that kind of showed this. So this trial that was done by English and all, men with coronary artery disease have low levels of androgens than men with normal coronary angiograms. And so this trial showed that men with coronary artery disease had a significantly lower total testosterone, free testosterone, and the bioavailable testosterone than men without coronary artery disease. Low testosterone levels in men were found to be associated with atherosclerosis. There was a study that revealed that men with coronary heart disease that were under the age of 45 had total and free testosterone levels that were significantly lower than controls. And that this group of men is a really scary one when it comes to coronary artery disease, because they usually have the type of arterial events that we call them the widowmaker. Their disease progression is not slow like our older patients, where their heart has had time to build little arterial channels around blockage. Their blockage happens very quickly. And so I think treating this age group of men is really, really important. Low testosterone, again, associated with increased risk for development of type 2 diabetes and metabolic syndrome. I think the important thing about this slide is that for people who have been diagnosed with diabetes, type 2, or diabesity as we call it, their risk for having a coronary artery event is the same as someone who's already had a heart attack. So I tell people who have been diagnosed with type 2 diabetes, you have to live your life as if you've already had a heart attack, because we really know that it's an equivalent, coronary artery disease equivalent. Testosterone has been shown to lower blood sugar levels. So again, the Endocrine Society is now saying that we need to measure testosterone in all the male patients with type 2 diabetes. So we're going to have a question and answer session. We're going to turn the camera off. If you have questions and you're watching this on YouTube, put it in the comments, and I will try to answer them as best I can.